Welcome to the Wednesday Yachting Luncheon, live from the virtual grill room of the St. Francis Yacht Club. We hope that you and your family are sheltering in place in a comfortable environment, and we look forward to joining you back at the club just as soon as conditions permit. Now, we're not able to go to the club because of this incredible pandemic, so it seemed appropriate to us that today's speaker would speak to that very subject. Born in Chicago, and he went to bachelor's through medical school at the University of Chicago, where he became a board certified doctor in internal medicine and infectious diseases. He remembers as a little boy being somewhat nervous and a little bit scared, paddling around in the Lincoln Park Zoo in Chicago in a pedal boat, and didn't have much to do with boats until he got back out to San Francisco, where he went sailing on San Francisco Bay. And he found that he felt totally out of control of his environment, but he was confident that his skipper knew what was going on. So, with a little bit of angst, he was able to bear up under the circumstances. Now, it's amazing to hear such tale from a person who's actually dealing with far more serious subjects every day. Because our guest then spent, after graduating from the University of Chicago, he spent 8 years at the Center for Disease Control, and 35 years ago joined the faculty of epidemiology at UC Berkeley School of Public Health, where he now is the head of that department. That is to say, the head of epidemiology and biostatistics at UC Berkeley School of Public Health. So we couldn't be more pleased to welcome Professor Art Reingold to the Wednesday Yachting Luncheon. Art, tell us, how long will COVID-19 be with us, and when will we really have a cure?
Well, that's a complicated question, and as Yogi Berra said, it's hard to make predictions, particularly about the future. I'm hoping we're in a much better place next summer in terms of once we have lots of vaccine and people willingly accept it. I'd like to think we're going to be in a much better place by summer. But of course, we'll have to wait and see.
This is the biggest pandemic in 100 years. Am I correct in saying that, Professor Reingold?
I think, certainly, fortunately, we haven't had anything like the death toll of the 1918-19 pandemic of influenza, which was estimated to have killed 40 to 100 million people at a time when the world's population was only 1.5 billion. So that was a pandemic of truly frightening proportions. The current pandemic certainly is, in terms of its economic damage and its impacts on people beyond hospitalizations and deaths and illnesses, is probably the worst pandemic since then. We've had other influenza pandemics that have caused a lot of problems, but probably this is the worst since 1918-19. I updated this talk yesterday. It's already a little out of date. And one of the problems with COVID-19 is pretty much anytime you prepare some slides, by the time you give the talk, it's going to be at least a little bit out of date. So I'll try and point out to you what things have changed. I'm going to go through a number of things that I think anyone who reads the newspapers will know. But just very quickly, I think you know that this disease, COVID-19, the 19 comes from 2019. This is caused by a novel, what we call coronavirus, and the particular virus is SARS-CoV-2. And I think the scientific evidence is quite good that this virus originated in a bat, perhaps in what you see here pictured on the right, a pangolin, but it almost certainly originated in an animal in China, and then unfortunately made it into people and became readily transmissible from person to person. All of the evidence we have suggests that the first known human infection occurred about a year ago, right now, in mid-November of 2019. It's quite likely all of this problem we're having originated from transmission of virus from a single infected animal to one or more people. Quite a frightening concept in some ways, because there are lots of other viruses out there in animals that people interact with or kill and eat or have other reasons to come in contact with. Just to say that while we've known about coronaviruses, corona from the Latin word for crown, because under the microscope they look like little crowns, that a number of coronaviruses have been known to cause the common cold, and to be quite limited in the illness they cause. But 2 novel coronaviruses have come up before. One in 2002 called SARS-CoV-1 that caused the SARS epidemic that originated in China and spread globally, but was ultimately contained. And then MERS, a Middle Eastern respiratory syndrome, in which the transmission of the virus is from camels to people, and we still have periodic outbreaks of that. This is just to say that the SARS outbreak of 20 years ago produced about 8,000 illnesses, about 900 deaths. As I said, it was ultimately contained through a variety of public health measures. And I think that led me, certainly, and others to think that this new coronavirus could be contained by similar measures, because this particular SARS virus has never emerged again, and that epidemic was extinguished. Unfortunately, that turned out not to be the case, as you all know, with COVID-19. So as of yesterday, you can read the New York Times, you can look at the World Health Organization, you can look at the Johns Hopkins website. The numbers you'll see of around 55 million cases and over 1.3 million deaths globally are clearly gross underestimates of the true number of infections and the true number of deaths. And if you're interested in the questions and answers, I could explain why they're underestimates. So I would take these numbers with a grain of salt. The numbers are certainly bigger than these. So, and if you, again, I like to take some of these things. The New York Times is doing a very good job. You can see the countries in red here are the countries with the highest known rates of COVID-19. And I think all of you know, sorry about the background motorcycle going by, all of you know that some of this reflects differences in ascertainment of cases and testing. So it's pretty complicated, but there's no question that we in the United States have a raging epidemic, as do a number of other countries in the Americas, like Brazil and Colombia, and certainly Europe at the moment. So this meets any definition of a pandemic. The first talk I gave on this disease was February 6th of 2020. And at that time, I just want to point out, we knew of 12 confirmed cases in the United States. You may remember President Trump said he didn't want to let 6 people off a boat because that would increase the number from 12 to 18, and he didn't want the number to go up. An interesting way to approach things. And of those 12 cases, 6 were in California, as you can see here. And so 12 known cases February 6th, and now in the United States, as of yesterday, something on the order of 11.2 million known cases and about 250,000 deaths. And again, these are underestimates of the true total. So clearly, we've gone very rapidly to widespread transmission in the United States. And so again, here you can see the United States that the most affected areas currently are the upper Midwest, states like Iowa and North Dakota and Wisconsin and Illinois and Michigan. Some of these were states which frankly did nothing to try to control this virus for a number of months, and unfortunately are now paying the price of that. You can see that we in California are in a much better situation according to this map, but you'll also know that within the last week or so, the state of California and counties like San Francisco have said that we're going in the wrong direction, and that they're going to impose more stringent control measures again. So we're by no means out of the woods here in California. I simply show this slide. These are estimates of back in February or March when there were 23 confirmed cases of coronavirus in the United States. In fact, the estimates are the virus was already widespread and that there were thousands of infections, even though we only knew about 23 confirmed cases. And
what's the shape of this curve mean? What does that mean?
Well, this isn't a curve. This is just, this isn't meant to be any kind of a curve. It's just meant to basically show where these hidden infections were back in March.
Okay,
It's
so
not
it's
really-
just volume, it's just a volume measurement. It's not,
It's just a volume measurement. And simply to say that counting the confirmed cases really only gives us a partial picture of what's going on because so many infections are asymptomatic or people don't get tested. And we know from several studies done right here in California back in April, for example, based on studies of antibodies in people, that there were far more people infected in California specifically back in April than the numbers of cases that we were counting. So there's quite good evidence of this, and again, a pretty good explanation for it. So, if you've heard about this virus, you know that perhaps as many as 40% of infections are completely asymptomatic. So people become infected, but they develop no symptoms. And certainly without testing, they would never know they were infected. There are many people who have a mild self-limited respiratory infection, perhaps with a fever. Again, if they don't get tested, they won't know if they had this virus. But then unfortunately, there's a small fraction of people who get infected who have a life-threatening infection of the lungs. A lot of argument about the case fatality, what proportion of people who get infected or get sick will die. But certainly the people being hospitalized or dying are a small fraction of the people getting and transmitting this virus. And of course, they're the tragic cases. You'll all be familiar with a little bit of this, which is that the test you've mostly heard about is called a PCR test, polymerase chain reaction, where they take a swab from your nose or from your mouth, and it typically takes a day or two or more to get the results back. Increasingly, people are providing what are called antigen detection tests. In fact, it was just announced in the newspaper this morning that the FDA has approved a test that you can do at home to yourself. You don't need, a doctor needs to prescribe the test kit for you. You can't buy it over the counter yet, but you can do the test at home and get your own result in about half an hour. So again, an example of what I wrote on the slides is yesterday is a little out of date today.
that's good news. That's terrific news.
It remains to be said that these tests may cost as much as $40 to $50 a piece. So they're not necessarily going to be the $1 a test that some people are hoping for, but they may turn out to be helpful as we move ahead. And then we also have tests of whether your body has seen the virus and has immunity or has antibodies and may be immune, but it's probably beyond this talk to get into details about that. You've all heard about some of the treatments that are out there. We've learned a lot about treating people with this disease in terms of supportive care that helps reduce mortality when people are in the intensive care unit, and that's very good news. High-dose steroids appear to be helpful in the later stages of this illness. And then you'll have heard about these other various treatments. I don't want to get into details here. The evidence for all of these others is frankly quite limited, and it's not clear how helpful they are, but they're certainly being given to people, sometimes in trials, sometimes just as treatment. So treatment may be getting better, and that certainly is good news. Just very quickly, the incubation period ranges from a couple of days up to perhaps as long as 10 to 14 days, although I think most transmission occurs within 2 to 5 days. You've all heard that this is spread through droplets that I cough or sneeze out, but also we now know can be spread through smaller particles we call aerosols. They can be generated by forceful talking or singing. And so it's not just 6 feet of distance and you'll be okay, because those aerosols can stay in the air and can travel further distances, making all this complicated. I know people have concerns about hand-to-hand contact, inanimate objects. The doctors are called fomites. So we do a lot of decontamination of surfaces. It's not clear how much transmission occurs via surfaces. And people who are busy quarantining their mail for several days or washing their vegetables when they get home before they eat them. To be perfectly honest, I'm not sure those measures offer much protection because I don't think the virus is transmitted very much by inanimate objects, but we can certainly talk about that. And the main problem is that the virus is in your nose and throat a day or two before you develop symptoms, or it can be present in people who are completely without symptoms, and they can transmit the virus to others, which makes our job in public health much, much more difficult.
What RO stand for?
So the R sub 0 is the reproductive number. And what that says is in a completely susceptible population, on average, how many new infections will one infected person produce? And anything above 1 means that the number of infected people will grow over time. So we were working hard to keep it below 1. But just for comparison, influenza is about 1.5. Measles is about 20, the most infectious disease we know. But this virus is plenty infectious enough to cause the kind of pandemic that we're seeing. And that's a part of our problem.
But isn't the number of people who would get it, who would catch it from a person who has the disease, a function of how many people they expose, how much they move about, whether they're indoors or outdoors? You're just saying on average, use that average number so that it's one measure of the virality of the.
Right. So this average number of how many people one infected person will transmit the virus to is an important thing for us to measure to understand a virus like this. But for me as an individual, what is my risk? Well, my risk, you're right, depends on my activities. And we'll get to that in terms of wearing a mask, being in crowded rooms with strangers who are not wearing masks, poorly ventilated spaces. So those increase my risk of getting infected. But this is really more of an estimate of once I'm infected, how many other people will I infect? And it depends on several factors.
Up above it says fomites. What are fomites?
So for the people who studied Latin in college, the word is actually should be pronounced fomites, but doctors are taught to pronounce it fomites. And fomites are inanimate objects that, like telephones,
Okay.
or payphones, or children's toys, or surfaces where the infection, the agent like the virus, ends up on the surface, then someone else touches the surface. That inanimate object is called a fomite.
My Latin teacher will never forgive me for this.
Well, I can assure you no doctor knows to pronounce it fomites, and if they did, they'd be laughed out of the room. The dictionary says that's how you pronounce it. I'm one of those people who reads the dictionary. You know, what are the measures we have in public health to try and reduce transmission and protect people? Well, they're listed here. Some of you obviously know that if somebody is infected in the hospital, we call those cases, and we isolate them to protect healthcare workers who are taking care of them and to protect other patients who may be around. So protective gear, what we often call personal protective equipment, PPE, for the healthcare workers who are taking care of these patients. If we have somebody who's been exposed and might be infected, but we don't know, when we remove them from other people, we call that quarantine. So quarantine is different from isolation, although a lot of people use the words interchangeably. Cordon sanitaire and protective sequestration, I won't get into, but for example, you know, if a city walled itself off and didn't let anyone come in from outside, as was done in the flu pandemic of 1918 and in the polio outbreaks of the 1940s and 50s, that would be an example of cordon sanitaire or protective sequestration. We don't do so much of that in the United States these days. Clearly, you've heard lots of discussion of masks and face coverings, which we believe are helpful in reducing transmission. Travel restrictions and border closings, I'm happy to talk about. In the old days, most of us didn't think those served much of a useful purpose for controlling epidemics. And you now hear a lot of crowing on the part of political leaders that limiting travel from China to the United States may have been helpful. In point of fact, a lot of the introduction of this virus to the United States came from Europe, not directly from China. And so perhaps this had a benefit, but it certainly, obviously, at the end of the road, didn't prevent us from getting the virus and having a large epidemic in the United States. Social distancing refers to all these unfortunate constrictions on our behaviors, like closing schools, closing restaurants, canceling Cal football games, or other gatherings, rock concerts, motorcycle gatherings, things of that kind, to reduce possibility of transmission. Hand washing is a great public health measure for reducing infections of different kinds. How effective it is against COVID-19, I think, is a little unclear, but we certainly want people doing good hand washing. Environmental decontamination is, as I've already referred to, cleaning surfaces in an effort to reduce transmission via surfaces. In China, the issue of closing the wet markets where these types of animals are sold for food, it certainly would be a potential measure. So we have lots of prevention and control measures, but some of them are hard to implement, and some of them are very, very disruptive and economically harmful to people's regular activities. And there have been a lot of politics about whether to use them or not. And I would just point out, in the United States, unlike many countries, we don't have a national policy about any of these things, and that individual states actually have the legal authority to make these decisions, not the federal government. So if a new federal administration comes in and says they're going to mandate masks, they can do that in federal buildings, but they can't do it across the country because our public health laws are basically made and administered at the state level, not by the federal government. Unlike many countries where the federal government can promote and enforce these kinds of measures. Here it's really at the state level that these things are done. We do think that if we could do all these things, we can reduce person-to-person transmission of this virus. You've heard reference to flattening the curve. And here the issue is that fundamentally, while we wait for vaccines to save us, can we reduce the strain and stress on our healthcare system, on our hospitals, on our healthcare providers, from being totally overwhelmed, as is happening now in some of the Midwestern states, by some of these measures. Even if we can't make the virus disappear at this point, we can potentially alleviate the burden on our healthcare system. But these measures have enormous impacts, reducing travel and trade. Any of you know about the impacts on stock prices or the economy or businesses of many different kinds of these types of measures. We saw some early hoarding of things like toilet paper and noodles and flour and other things. Once again, apparently stores are going to limit how much toilet paper you can buy out of concerns about running out of supplies. There's been stigmatization, particularly of Asian Americans with regard to this virus. We certainly have had an additional impact on the extent to which people trust authorities, such as health officers and scientists. We've had people talk about beheading federal scientists. We've had the local health officers' homes picketed and their children threatened. And so this is really a very unfortunate reaction to these problems. And of course, there have been political ramifications, certainly at the state level, in terms of what governors have been prepared to do, what mayors have been prepared to do, and frankly, what the federal government has been prepared to do over the last 8 to 10 months. But you all know all that already. And of course, there's also been a tremendous impact on other medical care. So children are not getting routine immunizations, which poses a real threat of measles outbreaks and other infectious disease outbreaks. Routine care of different types of surgery has been reduced. The University of California campuses that have hospitals and healthcare systems have lost hundreds of millions of dollars in revenue. Many smaller hospitals have closed. Many private practices are closing because people are not going for the care that they used to go for. So huge impacts on other health outcomes such as mental health, a variety of other problems. Some of you may be familiar with the Great Barrington Declaration, which was issued by a number of scientists, including some from Stanford. This is the basic notion that fundamentally all of these public health measures are misguided, that they're too injurious to the economy and to businesses and to people's health in general, and that we should, in essence, allow the virus to circulate and simply get over it and achieve herd immunity through letting people get infected and develop immunity through infection. They certainly want us to circle the wagons and protect the frail elderly in places like nursing homes because they're the ones at greatest risk of getting very sick and dying. But that in essence, we should try and protect those people who are frail and elderly and let everybody else get infected, and then we'll be over this problem. I do not agree with this approach, nor do most people in public health. And I think you can see that in places like South Dakota and Iowa at the moment, where the virus is running rampant, that it really is causing enormous illness, hospitalization, and death. I suppose the argument could be that they're not doing a good enough job of protecting the frail elderly, but I would point out that many of the frail elderly live in the community. They live in multi-generational homes. Not all the frail elderly are in nursing homes. Many, in fact, most of them live in the community, and it's very hard to protect them with the virus running rampant. So we could talk about this issue. Within our community, this is one of those health outcomes, like virtually all of them, which is unequally distributed. And it's the poor and marginalized and people of color who are most likely to become infected with this virus. And if they become infected, to get very sick and to die. That includes African Americans and Latinos and Native Americans. And part of this has to do with the fact that many of these people have jobs that they cannot do from home. Professors can teach from home, but people can't deliver your food to your doorstep by staying at home. So they often have jobs where they must be out and about, interacting with the public. They often live in more crowded neighborhoods and households, many multi-generational households. And so they're just more likely to get infected with this virus. And people who get infected with the virus are more likely to get very sick if they're either very old or if they have things like obesity and other underlying medical problems, which are more common among the poor and among communities of color. So we're seeing much worse mortality and hospitalization in the poor and in communities of color than we are in wealthier populations and in Caucasian populations. And that's true for virtually every disease in the United States, and certainly true for this one. Oops, sorry. I just want to point out that we still are seeing infections in healthcare workers, despite the greater availability of personal protective equipment. So that's very important, but we're still seeing quite a few infections in nurses, in people who clean rooms and work in hospitals and the like. And so that risk has not been eliminated by any means through the greater availability of personal protective equipment. This is simply to point out that it does appear you can become reinfected with this virus a second time, but we think that these reinfections are pretty uncommon. This is important when we start talking about vaccines, whether vaccines are going to be protective or not. But it would appear that reinfection is uncommon, at least in the short term. Whether you lose your immunity and can be reinfected a year later, 2 years later, is really completely unknown at the moment. So lots of controversy about what the body does in response to the virus, what types of antibodies it makes, what part of the immune system protects us. So that's perhaps beyond this talk, but there's lots of science being done to study how the body responds to the virus. And of course, finally, we'll talk a little bit about the vaccines. And this is, again, any day you make a slide of this, you'll be out of date by the time you give the talk. You all know that there are a number of different molecular approaches being used. There are over 200 candidate vaccines around the world, in Russia and China and India and Brazil, in Europe and the United States. But the ones that are getting the most attention at the moment in the United States are what are called mRNA vaccines being made by Moderna and Pfizer. And I'll come back to those in a second. The New York Times does a very good job. So as of yesterday, the New York Times shows that they track where the vaccines are in the United States, how many are in different phases of testing. And just to point out that there are no coronavirus vaccines currently approved for use in the United States. So that 6 number is actually refers to other countries, not to the United States. So at the moment, there is no coronavirus vaccine for use in the United States, but that's going to change, we think, quite soon. I'll simply point out that when we test vaccines, we typically give them first to animals and look at the immune response and safety in animals. We eventually give them to small numbers of people in phase 1 studies to look at safety and figure out the dosing, how many doses of how much to give. Then we move on to these other types of trials. And what's currently going on is all those vaccines I showed you are in different stages of testing. Efficacy trials of these vaccines currently have between 30 and 50,000 people enrolled to measure how safe they are and how effective they are. And then for a vaccine to be available for use in the United States, it has to be, the data have to be presented to the US Food and Drug Administration. And then they have to license it or authorize its use on an emergency basis before it can be given in the United States outside of a trial. Then the CDC and its Immunization Practices Advisory Committee, the ACIP, makes recommendations. And I would point out that both the FDA and the CDC external advisory committees are made up of experts. I've served on the CDC Advisory Committee, and they are really quite independent of all the political stuff that's going on or has been going on in Washington. And I think they can be completely trusted in their judgment. At least 2 countries, Russia and China, have decided to go ahead and start giving vaccines to large numbers of people without the benefit of the kind of trials I'm talking about. And they believe that their vaccines will be safe and effective. So they're giving them to large numbers of people, but they have not been through the kind of trials that are going on in Europe and in the United States and in Brazil and other places. There are lots of things we'd like to know about these vaccines, particularly how well they protect against the disease, how well they protect against severe disease. Do they prevent transmission of the virus? We're very, very interested in how well they work in different subgroups. So for example, do they work well in the frail elderly? Do they work as well in the elderly as they do in healthy adults? Eventually, we may want to know whether they work in children, but none of the trials currently include children. And England, at least, has said they will not be giving these vaccines to children. They consider them adult-only vaccines at the moment. How will they work in people who've already had coronavirus infection? So lots of issues like that. Of course, there's a huge focus on their safety, both in the short term, which is to say within the weeks to a couple of months after vaccination. Some people have concerns about longer term safety. And then another question is, for example, can you get this shot the same day you get a flu shot? So can we co-administer this vaccine with other vaccines? That's important, and I could list others. So these are all things some of these things we will learn initially from the trials that are going on, and other things we won't really know for at least a couple of years after we follow up people for longer periods of time. Again, in the United States, the Food and Drug Administration has a very standardized and strict way of reviewing things. And then either licensing a new drug or vaccine or giving it emergency use authorization after it's been through a thorough review. And so that will be forthcoming. You know that your tax dollars have been spent in large quantity to support something called Operation Warp Speed, in which the companies that are shown here have taken substantial sums of money from the government to speed up development of these vaccines. You'll notice Pfizer is not shown here. Pfizer did not take Operation Warp Speed money, but they do have signed advance contracts to sell large numbers of doses to the government once the vaccine is licensed. But the investment has come from them, not from the US government. And you can see the timing of the various trials of these various vaccines. Some of them require 2 doses, some require only 1 dose, and they use different methods to develop the vaccine. This is an out-of-date headline from last week when Pfizer announced right after the election, apparently withholding the data till after the election to influence the election, according to some people, that their vaccine was greater than 90% effective. In fact, today they released further data saying it's about 95% effective. So this slide is also a little bit out of date, but the Pfizer company has said that their vaccine is 95% effective against disease. And Moderna has also put out a press release saying that theirs is similarly about 95% effective. And I would point out that the very best vaccines we have are generally no more than 95 or 96% effective. So this is about as good as it gets when it comes to vaccines. The FDA had said they would accept a 50% effective vaccine, but these look to be much better than that 50% standard. So what's going to happen now? Well, of course, the timing of all this is a little unclear, and it's up to the companies, but when they present the data to FDA and CDC, they'll be reviewed immediately. FDA's advisory committee will vote, and based on that recommendation, the FDA would authorize the use of 1 or more of these vaccines. The CDC's ACIP committee would meet immediately and would also make its recommendations. There are already some numbers of doses that are available that can be used once this process is finished, perhaps as early as December, but more likely in early January. So most of the people I talk to think that this process will take place shortly after Thanksgiving, and that we could begin to roll out the vaccine by mid-December to the 1st of January.
So Art, help us with the acronyms, the second bullet point, VRBPAC.
Sure, so HHS is the Department of Health and Human Services, FDA is the US Food and Drug Administration, CDC is the US Centers for Disease Control and Prevention. FDA's External Advisory Committee is called VRBPAC, which stands for Vaccines and Related Biological Products Advisory Committee. ACIP stands for the Advisory Committee on Immunization Practices.
Got it.
And VRBPAC and ACIP are set up under federal law, governing federal advisory committees with lots of rules and regulations about conflicts of interest, composition. Meetings have to be open to the public so that anyone can watch them. Lots of rules.
So is it fair to ask the question, how long does it usually take to get through these 6 bullet points?
Well, you know, you hear people talking about 5, 10, 15 years to develop and get licensed and have available a vaccine. I would say that's really not what's reflected here. I would say currently there's very good coordination between FDA and CDC. So CDC basically makes sure that their advisory committee can consider things more or less immediately after the FDA approves them. So that there's very little delay between an FDA approval and a CDC set of recommendations. And the CDC advisory committee is typically working on those recommendations for many, many months in expectation of licensure in order to reduce any delays.
So what's it?
In this case, the delay will be as shorter than it's ever been.
So what's typical top to bottom to get to the 6 bullet points? Usually a year, 6 months, 3 years?
No, I would say for it to go from once the company presents its data
Yes.
in a rigidly controlled manner to the FDA, you're talking about weeks.
Okay, so from the top to the bottom of this could be as short as weeks. Okay,
Or I think it will be for this vaccine, yes.
great.
Now, the other thing people will know is because of, shall we say, concerns about the FDA's movement on some things like hydroxychloroquine, which I think most people judge to have been a politically enforced mistake on the part of the FDA because that drug doesn't work and has side effects. Some states have argued that we need an additional level of review. This is unprecedented and raises a number of questions. But New York State Governor Cuomo has set up a committee to review COVID vaccines separately, and so has Governor Newsom. And Governor Newsom in California have been joined by the states of Oregon, Washington, and Nevada in their review. I happen to be chairing that review. And it's rather controversial. But our expert committee, which truly has world-renowned experts on all this, will basically look at the data immediately once they're available. So we don't expect to delay the process. And we hope that if there's an additional stamp of approval, that people will be more accepting of the vaccine quickly, because many people have said they have concerns about the safety and do not want to be first in line or get the early vaccines. They prefer to wait. So we're hoping we can potentially give an additional layer of recommendations and support that may convince more people that what we know about the safety and effectiveness can be believed. So there's a separate California committee that's going to be doing that. I'd be happy to talk more about that. So just very quickly to finish up, I just want to point out that even once a trial has been done and a vaccine has been shown to be safe and effective, manufacturing millions and millions of doses of something is really pretty complicated. It takes, in our country, we've relegated this to the private sector. There are some large countries like Brazil and India that basically have government-run production facilities for vaccines, but there's nothing like that in the United States. We've left this to the multinational corporations like Pfizer and Merck and Janssen and the like. So, and they're experts in manufacturing things of high quality at a consistent, quality day in and day out, and putting it into bottles or syringes. But all of this is complicated. Nothing a professor knows how to do, or even a Nobel Prize winner. This is engineering and quality assurance in the industrial setting. And then, of course, you may know that these two vaccines that we've been talking about have to be stored at a very cold, frozen temperature while they're transported. That will pose some issues. 2-dose vaccines, we need to track who got the first dose and of which vaccine to try and get them a second dose of the same vaccine. So tracking and who should get priority is a very complicated issue. Trying to achieve equity in an unequal society is a complicated issue. But very important is once we're giving a vaccine to millions of people, we have an obligation to do studies of safety, to monitor safety, and to monitor the effectiveness in different groups. So those studies are already being designed and will be in the field once we start giving the vaccine to large numbers of people. And finally, 30 or 40% of the population says they're not going to take this vaccine. We can call that vaccine hesitancy. But if people refuse to be vaccinated, then it's going to make it harder for us to achieve herd immunity and to get this virus under control. So lots of public information, lots of attempts to counter misinformation on the web and elsewhere. So a very complicated set of issues here. Just to finish up, our national academies produced a report about how these vaccines should be distributed in an equitable fashion I was one of the authors of that report. And just to say that we put forward who should get priority in different phases as more vaccine becomes available. A number of other groups like the World Health Organization have done so. The US CDC has done so. But ultimately, each state is going to get its doses of vaccine. And each state is going to have to decide how to prioritize who has access to doses first. So it's recommended that high-risk health workers and first responders, older people living in nursing homes. The one problem is that phase one, there's not enough vaccine in the first stores of vaccine that'll become available to reach everybody in phase one. So even within phase one, there'll be difficult decisions to make about to whom to give priority. And states are already, counties in California already grappling with this issue. And of course, they may or may not decide to follow these recommendations. So lots of complicated things to discuss there. I find this sort of just one example. When our committee was meeting, we got a lot of input because the National Academy process is open to public comment. We got a lot of people saying they should be at the front of the line for vaccines. And one of the groups that was negotiating with the federal agencies were the people who dress up as Santa Claus in department stores. And the argument was that we need Christmas this year badly. And in order to have Christmas, we need Santa Claus in stores. And who could be at higher risk than somebody in a Santa Claus suit with children getting on his lap? So in fact, I believe you can see from this Wall Street Journal article that this actually was a highly orchestrated move in discussions with high federal officials. And then the Santas would apparently sing the praises of the government. And this was orchestrated by somebody who is now out on extended sick leave, who apparently had a nervous breakdown. So lots of interesting issues about priority setting for who should get the vaccine, to put it mildly. As I said, we have lots of concerns about people saying they don't want this vaccine, they don't trust the government, they don't trust elderly Berkeley professors who are making recommendations because of a long history of experimentation such as the Tuskegee study of syphilis in the 1950s. So we've got a lot of work to do, particularly in communities that are at high risk of this disease, to get acceptance of the vaccine. Just one last issue about the vaccine. Of course, the world has many billions of people. Poor countries can't afford a vaccine. And so rich countries and Bill Gates and others have put together an effort to raise a lot of money to buy vaccine for poor countries that will be distributed by the World Health Organization, something called COVAX, which also is trying to get equitable distribution of diagnostic tests and treatments for poor countries. So far, the US federal government has declined to participate in the COVAX activity, unlike virtually every other wealthy country. But this does raise an interesting question. If we don't have enough vaccine for our country, should we nevertheless devote some proportion of the doses we do have to poor people in poor countries? And if so, how many? At the moment, the current administration has no interest in this, but that could change after January 20th. So another interesting question. So to sum up, we have a global pandemic that continues to evolve. It's having severe health impacts as well as economic and other societal impacts. Vaccines are almost certainly coming quite soon, but they're probably not going to be plentiful enough to save us before next spring or summer. It would be my guess.
Thank you very much, Dr. Art Reingold, for that quick recap. Now, each of us who've been following the pandemic have been just as inundated by statistics. Wouldn't it be easier to keep track of what's safe and not safe if we had per capita statistics, not just gross overall statistics? America has the most dead from the pandemic, but also we're 330 million people. So wouldn't it be more productive all the way around to look at per capita infection rates, mortality rates, etc.
Yes, and those data are available and are looked at. So one can make those comparisons either state by state or country by country. So some people, for example, have said the United States is a collection of states. Europe is a collection of states, if you will. So you can compare Europe to the United States for the kind of metrics you're talking about. The United States doesn't look very good.
Yeah, on every measure, it just seems U.S. is doing badly. So what's the fastest way to spread? If you wanted to spread this quickly, what would you do? You'd have people do what?
The virus, you mean?
Yeah. If you wanted it to spread rapidly, what would you tell people to do?
Well, I would tell them to congregate in large numbers indoors without a mask, where there's a lot of either loud talking or singing or, people jostling each other or whatever, because the virus, we're quite certain, is transmitted most effectively indoors at proximity with poor ventilation. And so those are the kind of events that we would want to encourage. There's quite a legal battle going on about the extent to which a state can control or regulate such events. It bumps up against religious freedom when the state tells a church or a synagogue or a mosque how many people can be present or whether they can meet indoors versus outdoors. There are a lot of lawsuits about that. But similarly, there are lawsuits about other types of mass gatherings that the government has tried to prevent or control.
So then another variation on that question, what are the most dangerous places to go and what are the safest places to go now?
Well, I think a simple-minded statement about where it's safe is to stay home in your little bubble, in your pod, so to speak. But of course, that really is a huge hardship on people. And so, first of all, they still have to get groceries. They have to eat. There's a huge issue around schools and kids going to school, K through 12 and universities. But UC Berkeley has been totally online this fall to prevent people from gathering in classrooms. But kindergartners can't do online education. The answer is that minimizing your exposure in public to indoor spaces with unmasked people is important in terms of minimizing your risk. Doing more things outside than inside, if the climate permits. Those are the things we would encourage people to do.
So now, if a national leader thought, gee, a problem is an opportunity for team building on a massive scale, what if a leader, got on the tube and said, okay, everybody, this is a real serious disease, and if we all stay isolated for 3.5, 4 weeks, we can actually one time have a 4-week downtime and not have 3 weeks in this county, 3 weeks in that state, 3 weeks in this region, and keep varying it all around. Wouldn't we get over it faster if everybody together became inactive and kind of socially inert for some limited period of time and we announced it out loud and said, okay, we're going to stop?
Well, sure. I think that is certainly what we think would happen. I would just point out some of the complexities include people still have to get food. They have to have emergent health care. I mean, so you can't, but the reality is in some countries that works because they use the army and they don't fool around, right? Nobody has guns except the army. The army shows up and enforces things. And whether you like it or not, that's tough. China basically is able to do that. But the United States is not a society like that. And so if a leader implored people to do that.
Like depression, there were these fireside chats where the leader basically said, we're all in this together. Let's do A, let's do B, let's do C for some limited period of time. Remember, because he stopped to run on the banks, Roosevelt did.
I think one of the problems is, and I don't want to get into a political screed, but we're a deeply divided country politically. And I think whichever party that person was in, people in the other party will have their doubts. And perhaps we wouldn't have very good compliance by half the country.
To the numbers. On a per capita infection and otherwise illness rate, which countries in the world have done the best job and which the worst job?
Well, I think people point to New Zealand as an example that's done extremely well. Now, of course, New Zealand is an island. It's a true island, two islands,
I know.
with a small population and a lot of social cohesion.
They're the size of the Bay Area, 7 million or so. They're the size of the San Francisco Bay Area.
So they're always pointed to as a good example. People point to Singapore as having done a good job, for example, or Korea, South Korea, that is. So I think that there are examples of countries that have, where people have largely been willing to behave themselves, do what the leaders have asked in this regard. It's certainly much easier with a relatively small island population than it is a huge country like the United States. But in terms of who's done the worst, well, the United States is among the worst. China, once it dealt with its initial outbreak, has actually done quite well. So, most European countries are now having major problems. There was a piece in the New York Times today that the maritime provinces of Canada have done very well. These are small population and not as much traffic in and out of Nova Scotia as there is of Quebec, or Toronto. But they've apparently done very well as that part of Canada, for example.
So now we heard early about the vaccine from Russia. Was that phony news? Is it a good vaccine? What do we know about its efficacy?
We know nothing about its efficacy, and neither do the Russians, as far as I know. So they basically decided, based on making a vaccine that they thought would work, and giving it to maybe a few dozen or a couple hundred people, and showing that it made an immune response, it made antibodies, that was good enough. And based on that, they're giving it to large numbers of people on the assumption that it works. That's not how whatever concerns people have about the licensure and approval of vaccines in this country, we don't do what Russia did, and we don't do what China is doing, because China is doing something very similar. So you could argue that ethically what they're doing is good, because they can, get the epidemic under control and prevent mortality sooner than waiting 6 months to get the results of some trial, right? They can save lives in the meantime, and they're willing to take that risk. But that's not how we do things here.
So in the Valley, we have a term fast fail. Let's quickly discover that a product or a service doesn't work by, promoting it and seeing if it'll die or not. And you're saying that they're using a fast fail approach with these vaccines by distributing them before they're fully tested. Is that a fair comparison? Okay.
Yes.
Got it. So now what about the intellectual property of vaccine research? Are other countries stealing the intellectual property of vaccines like they've stolen other intellectual property from America?
So that has been asserted. I'm not an expert in this, so I don't know. It has been asserted that China and Russia have used industrial espionage to try and learn what some of the multinationals or the U.S. vaccine companies are doing, and steal that intellectual property. I have no idea if that assertion is true. To be perfectly honest, as a public health person, to me, vaccines are not an area where we should be having to steal intellectual property. We should be sharing intellectual property to get a world pandemic under control. It may be quite different from chips for computers or armaments, but of course, the companies will, if these vaccines are successful, they will ultimately make a profit. So, you could argue that the intellectual property is important to protect.
So now can you compare, we've been living the national response to COVID. Could you compare the response that we had to SARS? How different was the national response to SARS?
So, as I said, SARS ultimately was fully controlled, and we've had no recurrence of SARS. And I think that's why many of us were hopeful that we could do the same with this virus. I think the key difference, just to make sure people understand, is that while they're both coronaviruses that came from animals, it turns out they behave differently in the human body. And so the SARS virus, there's very little asymptomatic infection, very little asymptomatic transmission, and people mostly transmit to others when they're sick and in bed. And there's a lot of virus pouring out in their gastrointestinal tract. And so healthcare workers suffered a lot from that. But there wasn't a lot of asymptomatic transmission, whereas with this virus, as I've already said, there's a lot of asymptomatic transmission. So what worked for SARS in terms of isolation and quarantine and things like that just didn't work for this virus. And
what is it about this virus that makes young people less likely to get sick from it?
So we don't know the answer. There are lots of really good scientific questions like that to which we don't have the answers yet. I think people are busy studying that. You know, one theory, and I would call it a theory, is that children have a lot of the common cold. If you've ever had children, you know that you get more respiratory infections and diarrhea because you get it from your kids, and so kids get a lot of infections with these common cold coronaviruses, and perhaps they have some level of immunity to the COVID-19 virus because of all the infections they get with the common cold virus. But if you then ask the question, well, what about adults, right? How come? Because we've all had the common cold viruses a lot. You know, the argument appears to be that, well, maybe we had those as children, but we've lost our immunity, or as we've gotten older, we don't have the same robust immunity to coronaviruses that kids who have had their common colds more recently. That's a theory. It could be true. I don't know if it's true, but it could be.
Live animal markets. You said that you thought a bat in a live animal market, likely in Asia, likely in China. Now, I've been, in my trips to China, I've gone to the live animal markets, but I don't really know how many of them are there. How common are they in Asia or elsewhere?
First of all, we used to have them in San Francisco, you know, and it was actually quite controversial 15, 20 years ago when, for both health reasons and animal rights reasons, there was an effort to close live markets in San Francisco. Live markets are a cultural phenomenon in certain cultures, particularly Asian cultures, where, you know, you don't want to buy a chicken wrapped in plastic. You want to investigate its hind parts and see if it looks like a good chicken before you buy it. And then it's slaughtered on the spot and you take home a just killed chicken. And so there were parts of the San Francisco community that, you know, went to live markets, at least for things like poultry, maybe turtles or things like that. And it was a very controversial issue, you know, to shut those down and prevent people who, that's how they grew up and what they valued, from having access to that. So in Hong Kong and in southern China, and there certainly have been wet markets for things like poultry. I've seen them, I've been to them when I went to Hong Kong during SARS.
Right.
And so there are certainly alleged to be markets where you can buy pangolins and bats and palm civets.
And snakes in a live market in China.
Snakes and, you know, maybe rats and who knows what else. And so, you know, one argument is we should put those out of business. And I would just make two comments about that. One is that one concern is when they're put out of business, if the demand remains, there'll be a black market. Just like in New York City, there's a black market for raw milk. Raw milk cannot legally be sold in the state of New York, but people in New York City will pay enough. You can get raw milk brought in by an underground railroad through a black market.
Unpasteurized is what you're saying.
Unpasteurized, right. And so, you know, there could easily then be a black market of the same products, you know. That's one problem. The other problem is that while markets are an issue mostly in China or in Asia, the other problem is in sub-Saharan Africa, where there are markets, and to say you cannot hunt and eat monkey or hunt and eat bats, you can say that, but it's very hard to enforce. And for some people, it's their major source of protein. So if you're not prepared to do something about that, it's unrealistic to think you can stop the practice.
You're an epidemiologist, and we're in the greatest pandemic in what people might describe as 100 years. And your phone and your profession is, your phone's ringing off the hook, and your profession is, all about the most timely subject right now. When is this virus going to be old news?
So I'm optimistic, actually, that I think by next summer, we will have a much improved situation, that people will be able to do many of the things they want to be doing that they're not doing now. Will things look exactly like they did, 18 months ago? I don't think so. And I think part of that is because, people like me have learned you don't need to get on a plane and fly to Geneva and have all that travel. You can actually do things by Zoom and be productive. I think businesses have learned new ways of doing things. So I think there are going to be some permanent effects, and some things may change. But I think that many of us will be able to go back, to playing tennis or getting on a boat or doing other things by next summer.
By you're saying July 2021.
I'm hopeful.
And by that time, it'll be because we've got we'll all have been vaccinated. We'll all have taken a vaccination shot, 2 vaccination shots. Is that what's going to cause that?
I think that's what's going to get us there. There'll be some element of natural immunity because the virus is still circulating widely. But I think between the widespread infections and vaccine, we'll be in a much better place. But I also have to candidly admit that I think that there will be people who absolutely will not accept the vaccine. And so I don't know what the coverage will reach. And I think there's a really interesting legal question about whether you can compel someone to take the COVID vaccine or not, the way we compel children, for example, to be vaccinated to go to school, or the way some healthcare organizations compel healthcare workers to have influenza vaccine. So I think there could easily be legal battles over that, but I think that there'll be many people who never get the vaccine. I'm sorry to say.
You make it a requirement to attend a public school that you have to have, one of the prerequisites is you have to have a shot. There still will be people who will be cheating and not do that.
Well, so I don't think that's going to be true for the COVID vaccine, because I think that we're a long way from using it in kids. I don't know what the advisory committees are going to say about using it in kids, but at the moment, I don't think there'll be recommendations to give it to children because we don't have any data from any of the trials in children.
Right.
And it said children generally don't seem to get very sick. So I think from the school point of view, if we can vaccinate teachers so they feel safe being in the classroom, I suspect we're not going to be vaccinating young children. Now, high schools, maybe, colleges, maybe, but probably not K through 8.
So Dr. Art Reingold, chair of the Department of Epidemiology at UC Berkeley School of Medicine. We very much enjoyed your talk today at the Wednesday Yachting Luncheon. And thank you so much for sharing your knowledge on this very, very timely subject. Those who want to watch this program can see it, of course, on the Yacht Club's YouTube channel, on Facebook, and on the Yacht Club website, where it'll be archived with all the other talks. So Art, thank you so much for visiting with us on the Wednesday Yachting Luncheon.
I'm happy to do it.
With that, our luncheon is adjourned.